Good afternoon, everyone. This is Aditi on behalf of IJCP. I warmly welcome to all our respected doctors and participants for today's digital live session. Today's topic is the rise of metabolic pregnancy, managing pregnancy in obese, diabetic, and PCOS patients reflects a growing clinical reality with increasing rates of obesity, diabetes, and PCOS. Pregnancy care has evolved beyond routine antenatal management to a more complex, multidisciplinary metabolic approach. This session aims to highlight practical strategies, evidence based interventions, and holistic care pathways to optimize both maternal and fetal outcomes. So, it is my privilege to introduce our esteemed speaker for this afternoon, Dr. Sujit Ash Sir. He did MBBS, DNB in obstetrics and gynecology. He did fellowship in minimal access surgery. He did diploma in gynecological endoscopy from Kehl University, Germany. He is senior consultant and obstetrics gynecology in PD Hinduja Hospital in Mumbai. Dr. Ash is a well known clinician, endoscopic surgeon, and thought leader in women's health. His popular podcast channel is Guy from Gynec has created a strong impact across social media by addressing women centric and sensitive health topics with clarity and compassion. With great pleasure, I now hand over the session to Dr. Sujit Ashsar to take us through this highly relevant and engaging discussion, sir. So, this is over to you. Thank you.
Thank you, Adam. Good afternoon, everyone. So, actually, today we'll be talking about managing pregnancies and metabolic conditions which are rising in our daily practices. So, the idea is to understand the epidemiology around obesity, diabetes, and PCOS, and how this impacts pregnancy and it can lead to adverse pregnancy outcomes. And whenever you come across such patients, we need to identify it antenatally so that we can manage the intrapartum and postpartum challenges. More so, what I also stress on that the factor should be the preconceptional advices and how this will impact the entire pregnancy and how even the postpartum health. We'll be taking in ideas from RCOG, ACOG guidelines along with ADA and ESHRE. And overall, we'll discuss the implication on the mother, the fetus, and the long-term implications, not just for the mother, but even for the baby. So yes, this is a burden globally where lifestyle changes has affected pregnancy and there's a delay in even childbearing age group, which is affecting the risk of diabetes and PCOS in general. These are known to be significant contributor towards morbidity for mother and the baby, and there are risk of higher chances of preeclampsia, cesarean, PPH, and infections. This not just affects the mother, but even the healthcare utilization that is affected with a multidisciplinary approach because the patients are more prone to getting cardiovascular issues and metabolic diseases in the long-term future also. Now, tackling one by one, currently, firstly, we talk about obesity. As per the WHO, the guideline which says that BMI of more than 30 kg per meter square is classified as maternal obesity. Globally, the prevalence is around 20 to 30%, which is predominantly seen in urban populations. And when it comes to India, 15 to 20% urban antenatal population are showing obesity in pregnancy, which is a steady rise in the reproductive age group. Again, we'll be discussing about all these things in different sectors. The most important, as I said, is preconception counseling, where you ask the patient or discuss the patient regarding weight reduction before conception. Even a weight reduction of around 10% is beneficial because this will improve ovulation. And once the ovulation improves, it will improve the pregnancy outcomes. Once you have a weight reduction, it will also help in optimizing the comorbidities that can be associated, which can include high blood pressure, diabetes, and obstructive sleep apnea. Recommendation 5 milligram per day of folic acid is essential because this is known to reduce neural tube defects in obese women. And you should counsel the patient regarding gestational weight gain so that this is where your pregnancy goals would be achieved. In fact, the idea is that even in pregnancy, the least amount of weight gain is also good in such patients because the myth that the mother should gain weight in pregnancy doesn't work in cases of obesity. The weight gain should be for the baby and not just for the mother. And this is how the counseling around the weight gain will help for the mother and the outcome of the pregnancy when you do it in preconception of the case. The second aspect would be antenatal challenges, where gestational diabetes mellitus is something that needs to be targeted on. Because of obesity, there might be insulin resistance, which can progressively increase with the gestation. Hypertensive disorders can also show up because of endothelial dysfunction that can happen, and this can contribute to even preeclampsia. Thromboembolic disease can also go on a high because of hypercoagulable state, which happens in obesity, and hypercoagulable state, which is also seen in pregnancy. So, this is a twofold risk which can add up. There might be difficulties in clinical assessing of the pregnant uterus. Clinically, when you do an abdominal check, that will be difficult. And even the imaging is obstructed because of the obesity or the fat content in the abdomen. And therefore, the anomalies qualities can also be rendered poor. When we think about delivery, intrapartum induction and failed induction rates are on a high. Because of postdatism, JDM, or preeclampsia, you decide to induce the patient, but because of all the obesity and the hormonal imbalance, the induction might not work, and this might lead to increased rates of failed induction. There might be also prolonged labor because of reduced uterine contractility. There might be risk of operative vaginal delivery, wherein both emergency or elective cesarean rates will be higher. And when you think about cesarean, there might be complication that can be associated because of difficult anesthesia, because of the fat content around the oral cavity, or because of the fat around the spinal cord. These both aspects of anesthesia is something which can be affected. Wound infection can increase because of abdominal obesity and also because of uterine contractility, which is rendered not very good. It can also lead to PPH risk. Coming to the postpartum things and long-term implication for the mother, PPH, as we discussed, which can happen due to uterine atony or prolonged labor, more chances of infection, which can lead to poor wound healing and immune dysfunction, which can also contribute in infection. And the mother can have long-term risk of obesity and metabolic syndrome in the future. For this newborn, the newborn that is born via this entire phase can have macrosomia, can have shoulder dystocia because of improper weight distribution during the growth in the fetal stage, and the baby can also have features of childhood obesity as per the Barkan's hypothesis. Now coming to diabetes in pregnancy. Diabetes in pregnancy, there are different classifications which I'm not going into detail because this is something which I expect you all to know. But just a brief that GDM or gestational diabetes mellitus is where the glucose tolerance test first is deranged in the pregnancy, that is GDM. In pre-existing diabetes, what we call as pre-gestational diabetes, this is there before conception and it can be either type 1 or type 2. When you come to prevalence, the prevalence of GDM per se in India is 10 to 14%, which can be attributed to genetic susceptibility or to lifestyle factors also. And as per the recent talks that we have, India is often referred to as the GDM capital of the world. Preconception counseling again becomes important in this. What we need to know or what we need to target is the HbA1c levels. HbA1c levels of more than 8 is definitely known to lead to complications, and more than 10 is something which can demand even a miscarriage or a medical termination of pregnancy. What we need to achieve is an HbA1c of less than 6.5 before conception because it's known to reduce congenital malformations. What we usually see the most common is the cauda equina syndrome. There might be a discussion regarding what drugs that need to be taken. So that is why preconception counseling again becomes important. We need to know which are the pregnancy safe drugs which the patient can take during pregnancy, or even consider shifting to insulin if the HbA1c levels are too high. You need to screen for complications such as nephropathy or retinopathy because these are affected in pregnancies also, and the risk becomes even higher when the patient is pregnant with an existing retinopathy or nephropathy. As always, start with a folic acid tablet, in this case to reduce also the neural tube defects, which we have already discussed, which can increase because of high HbA1c. As I said, unplanned pregnancies carry the highest risk. If you have an HbA1c of more than 8, the congenital risk malformation significantly goes high. Antenatal challenges, there might be poor glycemic control because of hormonal changes, and this leading to insulin resistance. After the placentation is done, even the placenta produces human placental lactogen that we are aware, that also can affect the glycemic control. Especially in long-term standing diabetes, the risk of preeclampsia also increases. And for the baby, we are already aware that because of maternal hypoglycemia, there might be fetal hypoglycemia, which can lead to polyuria, and this can lead to polyhydramnios, which will also complicate the pregnancy. Because of poor sugar control, there might be risk of UTIs and candidiasis, which can lead to recurrent infections in pregnancies, and fetal growth abnormalities can be present. Therefore, your antenatal anomaly scans become very important in such cases. The cornerstone of management in antenatal control is the tight glucose levels that you need to achieve either by routine checks or either by continuous glucose monitoring, which is a new thing which is there. In fetal complications, congenital anomalies in pregestational diabetes can be leading to cardiac or neural tube defects. In cases of hyperinsulinemia, there might be macrosomia, as we discussed, macrosomia and polyhydramnios and a megaloplacenta. All these things run hand in hand in cases of improperly managed blood sugars. You might have IUGR in cases of vascular insufficiency or placental insufficiency, which can be noted. These are more common in pre-existing diabetes mellitus. And you might also see IUFD in cases of poor glycemic control. An anomaly scan or and along with a fetal 2D echo becomes essential in detecting such complicated anomalies at the earliest. Timing of delivery in such cases becomes critical because you need to weigh the risk and the benefit between the stillbirth risk and the prematurity and giving a good outcome for the pregnancy. Shoulder dystocia risk will also happen because of disproportionate fetal growth, as we discussed in obesity also. Cesarean section can be needed in case of macrosomia where the baby weight is more than 4 kgs, leading to CPD. A neonatal hypoglycemia preparedness is important because these babies, once they come out, they can move into severe hypoglycemia, which becomes leads to hypoxia and the baby's APGAR score becoming very bad, or overall in the initial few hours, the baby can go into cardiac imbalance. So that is why it becomes important that you have NICU support in such cases wherever you plan to deliver this patient. In the future risk, if the mother has landed up with GDM, her risk of getting type 2 diabetes mellitus is around 50 to 70% in the next 10 years. Obviously, these patients also will have cardiovascular compromises, so CVD is a risk. A postpartum OGTT is something which is always essential to outcome to understand the outcome of these patients, and this is something which is often missed also. So when the patient follows up at around 6 weeks or 12 weeks, this is something which I ask you all to pay a little attention, where a postpartum OGTT will be helpful in understanding the risk. In the child, obviously, these things are running hand in hand, where the child will develop or might develop obesity and metabolic syndrome, which is again related to Barton's hypothesis. Now, coming to PCOS, prevalence of PCOS in the reproductive age group is around 6 to 15%. We know the criteria, the old dated or Rotterdam criteria, which says that hypoandrogenism, anovulation, and polycystic pattern in the ovaries in ultrasound is something which is used to label PCOS. But nowadays, we have understood that this is not just a metabolic disease, it is also an endocrine disorder which can run hand in hand along with the metabolic pattern, and this is all correlated to the insulin resistance, which is affected, which leads to inflammation, female hormones imbalance, and even the metabolic damages. In these cases, the preconception becomes very important, wherein weight optimization is essential. This improves ovulation and the pregnancy outcomes. Glycemic assessment is essential, where you screen for impaired glucose tolerance in the beginning itself. Ovulation induction counseling is something that we do on a daily basis, on a regular basis. AMH marker of fertility in these cases is a little dicey because AMH is usually false high in cases of PCO. Therefore, this is not something where will be helpful with in cases of counseling such patients. When you think about induction, AMH just gives you an idea where you discuss regarding the ovulation or the hyperstimulation syndrome. That is why Letros currently, which has least risk of OHSS, is the first line for ovulation induction in such cases. Metformin, the role has to be discussed with the patient because this is something which is known to improve ovulation, which is known to help with weight loss also, and therefore it will help into improving the pregnancy outcomes. Whatever the discussion that you have, it has to be understood that this has to be an individualized counseling approach rather than creating a blanket idea for all the patients. You have to discuss all these things individually on every patient to patient basis. Antenatally, in these patients, the risk of GDM increases around 2 to 3 folds because the underlying cause for PCO is same as in GDM, wherein you have insulin resistance, which can happen. Again, endothelial dysfunction in such cases because of inflammation can lead to higher risk of getting preeclampsia for such patients. Because of hormonal imbalance and because of progesterone insufficiency in cases of PCO, there are a higher chance of having early pregnancy losses. And overall, the risk of preterm birth increases because of either spontaneous preterm births or because of iatrogenic, because you have to balance the risk versus benefit to give the better outcome to the patient. Higher induction rates, again, in such patients because of macrosomia associated, or because of IUG, or because of inflammation, or because of GDM and hypertensive disorders that can complicate such pregnancies. Higher induction rates also have a higher failure rates, therefore demanding a cesarean delivery, which can be also secondary associated to the obesity or failed induction. Associated obesity and insulin resistance can complicate the pregnancy, as we discussed in cases of diabetes and obesity complicating the pregnancies. In the long term, these patients, these mothers, do definitely carry a risk of developing diabetes mellitus in the recent future. And there will be persistent metabolic disorders which can affect the patient because of PCO. Since you get this opportunity with the patient, you should counsel the patient for the future implication, not just because of pregnancy, but because of PCO complicating and leading to metabolic issues in the future. In the newborn, this baby can either land up with LBW, low birth weight, or because of microsomia. There are also implications of future metabolic risk in the neonate also. So, in the comparative risk, what we see is that obesity is a condition which is leading to either GDM or because of leading to preeclampsia and cesarean rates. In diabetic pregnancies, obviously, we understand that it is a sugar imbalance which can happen, but it has a lesser chance of leading to preeclampsia compared to obesity and lesser cesarean rates, provided it is managed properly. In PCOS patients, the risk of GDM also increases, but again, if it is managed properly, the risk of cesarean rates can go down. The key principles that are important whenever you need to manage such patients are the following. You have to do a proper preconception counseling, and that is where you optimize everything right from the antenatal checkups, antenatal clinical importance, and the lifestyle changes where you should reflect. This is the most effective intervention window that you get between you and the patient and the disease. Whenever such patients get pregnant, it is important to have a team of other doctors who will be important into highlighting different aspects in the entire pregnancy. You will have an obstetrician, that's you. You'll have a physician in the loop to manage all the other interventions regarding the blood sugar, regarding the blood pressure, and regarding all the cardiac or the nephro or the ophthal importance that is there. A dietitian becomes very important. All my patients go through a dietitian at after 12 weeks. So this is something I do in routine. But in these cases, it also becomes more important that they go through a dietitian to understand a balanced diet where the baby's weight is also not affected and the mother also doesn't put on a lot of weight. And obviously, a neonatologist who will manage all the complications or discuss all the complications which can be associated during antenatal and as well as postnatal phase. Antenatal surveillance is individualized. You have to target each patient on their merit, demerit, and you have to plan the delivery accordingly. Like I said, the risk versus benefit ratio becomes important, where you counsel the patient regarding if you need to deliver early or if you need to deliver the patient as per your choice of selection of the weeks. And long-term follow-up becomes very important in such patients because of the implication of metabolic disorders which can crop up in the future when the patient lifestyle is not managed properly. Therefore, the role of lifestyle interventions, diet modification with low glycemic index and a balanced nutrition, which is essential. Physical activity is very important, which improves the insulin sensitivity also. All my patients go through a Lamaze class, which is as essential as any nutritionist, where the patient is more flexible, the patient is doing certain physical activity and not just treating pregnancy as a disease and being at home and doing nothing. Weight gain monitoring again becomes important. Like I said, all my patients have a BMI calculation, which is their pre pregnancy as soon as you get pregnant, because this is what will help me decide the weight gain for the patient in the entire pregnancy journey. I've had patients who have, in fact, lost weight who were obese during the pregnancy, keeping in mind that the baby has gained weight in the entire pregnancy, which is essential. And postpartum lifestyle counseling again and again, since the patient has come to you, it is important that the patient understands the implication of obesity, diabetes, and PCO, which can impact their entire outcome in the future journey of life. And the recent things which are there are pregnancy as a metabolic stress test, which is an identification for future cardiometabolic disease risk in mother and the offspring. This is something that we are looking into. Intergenerational programming concept, maternal obesity, and hyperglycemia is leading to epigenetic fetal changes, and therefore the baby is landing up with higher risk of getting obesity or getting diabetes because of something which has passed on from generation to generation. Early risk stratification becomes important or essential, wherein the first trimester BMI, HbA1c, and metabolic profiling can help into guided intensity care for the patient during the entire pregnancy. Expanded postpartum care model, which is focused beyond the 6 weeks of pregnancy, like I told you, beyond the 6 weeks of delivery, wherein the patient is counseled and looked into to prevent or avoid long term non communicable diseases which can complicate the patient's lifestyle. And finally, digital health integration, which is telemonitoring, which is better because it improves compliance and outcomes. The patient doesn't need to visit you again and again in cases of long term follow up, and this can be done with the help of digital intervention, which are easily available these days. Obesity, individualized gestational weight gain is the target with rigid IOGM cutoffs, which are something which is not currently used as frequently. Early dose low aspirin use for preeclampsia prevention, moderate risk, is something which is advised, and weight adjusted LMWH can be considered to reduce the risk of VTE also and to reduce the risk of placental insufficiency. In diabetes, CGM improves glycemic control and neonatal outcomes. These are recent things which are coming into practice. You need to recognize and treat early onset GDM so that you're not waiting for the GDM to complicate the pregnancy and then think of starting with the treatment. An individualized delivery timing is something which will help based on the control of the sugars and the fetal growth. In PCOS, it is reconceptualized as a metabolic disorder, as we discussed about it, not just endocrine, but also metabolic, pregnancy, unmasked long-term diabetes and CVD risk. Letrose, which we discussed, is the first-line ovulation induction, gives higher live birth rate and lower multiple pregnancy risk. Selective metformin use is reserved in cases of metabolic indication and not just to use for a routine miscarriage prevention. And precision medicine approach emerging, AI-based prediction which are there, which can develop models and biomarker guided care so that we find out the future risk which can affect the pregnancy or the entire lifespan for the mother. The take home messages for today: prevention begins at preconception. Early identification will help you reduce the morbidity for the mother as well as the perinatal outcomes. Postpartum care becomes crucial where you discuss about a lot of other things and not just the pregnancy aspect, because eventually the implications extend beyond pregnancy. So, in conclusion, obesity, diabetes, and PCOS significantly impact pregnancy outcomes. Evidence based, guideline driven care improves your mother's and the neonatal health, and focus must extend to future health of the mother and the child. With the modern management of high risk pregnancy, the focus is now on prevention, personalization, and protection of future health for both the mothers and the kid. Thank you.
Thank you so much, sir, for this wonderful explanation, sir. Sir, so with all your permission, sir, shall I take question one by one? Sir, I am audible?
Yes, you're audible. You can take the question.
Okay. Thank you, sir. So the first question is, sir, how does maternal obesity alter placental function and pregnancy outcomes?
Maternal obesity will lead to impaired glucose tolerance and it can lead to endothelial damage. Endothelial damage will affect your lead to placental insufficiency, and impaired glucose will affect the fetal growth and therefore it can affect in the fetal outcomes.
Okay, thank you so much for this brief answer, sir. So the next question is, how early should metabolic screening begin with in high risk pregnant women and parameters are most crucial?
So again, preconception is more important. Don't wait for the gestation or pregnancy to begin. The parameters that you always consider in such cases is your sugar level, your cholesterol level, blood pressure, BMI, and your thyroid. These are something which are mandatory for all patients. In PCO, again, you have to think about other implications which can affect. So, in cases of diabetes, obesity, and PCO, not just the metabolic screening, but screen for the heart, screen for the kidney, and the eyes also become important because pregnancy will complicate all these aspects. So, preconception is the idea to target and prevent all these complications which can affect in pregnancy.
Okay, thank you so much for this brief answer, sir. So the next question is a practical based question. The question is it true, sir, that women with PCOD and thyroid can never get pregnant, or it's just a myth?
Just a myth. Nowadays, anyone can conceive depending upon who you're showing. IVF has reached to beyond levels that we can think about, but not even IVF. If it is managed well, you can even conceive naturally or with certain induction agents. You don't even think about IVF. So those are myths which are there in the bygone eras.
Okay, thank you so much, sir. I hope it will clear to all the patients. So the next question is, what role do lifestyle intervention and preconception counseling play in improving outcomes in metabolic pregnancies?
The most important point that is stressed on throughout the entire presentation is preconception counseling, because that is where you discuss the lifestyle modifications. Lifestyle modifications in metabolic disorder are always in two parts. One is obviously your diet and nutrition supplementation. The second is exercise. You need to have a nutritionist, you need to have a person who's looking after your exercise, because I believe that unless and until someone is behind you and getting these things sorted for you, you're not going to do it alone. Therefore, pre-pregnancy, pre-conception counseling, nutrition, and exercise are something which are must for all the patients who are complicated with metabolic disorders.
Okay, thank you so much, sir, for such insightful and practical engaging session, sir. With all your permission, so shall I conclude the session?
Sure. Thank you, Ada. Thank you,
Uh,
everyone.
Answer your approach to managing metabolic challenges in pregnancy along with real world clinical perspectives was truly valuable, sir. So on
Thank you.
behalf of IGCP, sir, I extend my heartfelt thanks to you and all the doctors and participants who joined us today. Wishing you all a safe, healthy, and wonderful evening ahead. Thank you and take care. Thank you so much, sir.
Thank you. Thank you. Bye bye.